Are you start?
Yeah.
Okay. A warm welcome and good evening to all. Rural Service Bootcamp is back with another edition this Sunday. We'll be having a session on ophthalmology by Dr. Daniel and moderated by Dr. Anna Philip. Dr. Daniel is from the St. John's MBBS batch of 2014 and has completed 2 years of rural service in St. Peter's Hospital, Attapadi. He worked in emergency medicine and as a visiting industrial medical officer in Palana Institute of Medical Sciences, Palakkad. In 2023, he worked as a JR in critical care medicine in St. John's and currently works as a trust grade core level doctor in acute medicine in Leicester Royal Infirmary, UK. He has a keen interest in ophthalmology and hence is apt to take today's class. Our moderator is Dr. Anna Philip, who completed her MS Ophthalmology from St. John's Medical College and Hospital and currently works as an SR in St. John's. We warmly welcome both of you to this session. A few reminders. Please keep yourself muted throughout the meeting, and if you have a query, please type it in the chat box or raise your hands. A feedback form will be shared in the chat box as well as in the WhatsApp group. Please fill it before you leave the meeting. Thank you. Over to Dr. Daniel.
Thank you, Tara, for introducing us, and thank you, Anna, for coming here as a moderator for this webinar. I'm just checking if this webinar is being recorded at the moment.
Yes.
Yes, okay. So guys, today we are taking a webinar on ophthalmology. So how I have divided the slides is, so the main reason we are doing this is so that you guys, when you get a patient with an ophthalmological disorder, you would know how to approach it. So we have divided it into three subtopics. First being red eye. The second one is ophthalmological emergencies and injuries to the eye. There's a lot of topics which come in all three. So you might not find some of them in each topic, but you will find towards the end of it. And let's begin with the seminar. So the first topic we are going for is red eye. I'm sure you all come across a patient who has come with red eye, and you would have thought, okay, what is it? And should I treat this patient here? Do I have to refer this patient? Or is it something simple? Is it something more emergency? Because in red eye, we do have some symptoms which just require some topical antibiotics or topical drops to help them. But then there are others, if you don't refer them, then the patient can lose his vision or have serious complications later on. So I'll start with a slide. This is from UpToDate. It tells you what are all the things that you can manage in a primary setting. So that will be somewhat similar to your rural bond centers or any hospital that is small and doesn't have an ophthalmologist or a slit lamp or have a theater to do the procedures. So those include stye, chalazion, blepharitis, subconjunctival hemorrhage, conjunctivitis, corneal aberration, corneal foreign bodies, lens overwear issues, and some dry eye and episcleritis. At the same time, there are these emergencies and urgent referrals which need to go to the ophthalmologist in a day. So if you see any angle claustral glaucoma, hyphema, hypopion, iritis, infectious keratitis, or scleritis, you need to refer them. I'll go through all of this during the course of this webinar, so you don't have to remember this. But then later on, if you come back to it, this is an easy guide to tell us what to do for each. Going to the next slide. So we'll start with something more easier to manage, which is acute conjunctivitis. As you know, most of our patients coming with red eye may be some kind of conjunctivitis. So this is the most commonly seen malady we see in the eye. We have acute conjunctivitis could be because of viral, bacterial, it could be allergic, and in some cases quite non-specific. I'll start with bacterial conjunctivitis. And how I'm going to present all of this is I'm not going to read out the whole thing. So whatever I have highlighted in color, so those are the ones we need to look for, because everybody is going to have some conjunctival congestion. That's not really going to help you differentiate between the issues. So in bacterial conjunctivitis, we'll see some matting of the lashes, mucopurulent discharge, and the patient will complain of a gritty sensation or sand in the eye kind of sensation. So the main thing is the discharge. So if you see discharge, redness, gritty sensation, they don't have any problem with their vision as such, visual acuity is normal, then we should think about bacterial conjunctivitis. And one thing to remember is if they are using a contact lens during the treatment, ask them to remove it for the duration of the treatment, and then start them on some topical antibiotics like moxifloxacin, which should be easily available in your bond center. So give 1 drop 4 times a day and ask them to use for 5 to 7 days. And you can give them especially if somebody has matting and gluing of the eyelashes in the morning, can give them tobramycin eye ointment, which should help with the issue. And if it's a child whom you're saying the safest to use will be a tobramycin eye drop. You can, if the patient has photophobia, advise them to use glasses. If there is a lot of irritation, you can use antihistaminics. And but then one thing to know is that this could be you might come up with as unilateral, doesn't all, and sometimes bilateral. So tell them to have good hygiene, don't touch your eye, don't, wash your hands more regularly, and also no need to put the drops in the other eye if it's not affected because it doesn't have any prophylactic effects. So tell the patient if you don't see any improvement in the next 2 to 3 days, they need to go directly to an ophthalmologist. Next, coming to viral conjunctivitis. This could also be both unilateral, bilateral. So the main difference is there is more of a watery or mucoserous discharge. There's no pus. They still can have some gritty sensation and it's quite acute. And the patient might come up with telling that there's some coryzal symptoms, some cold and cough and all in the last weeks or so, or still may be having it. So these all points towards a viral picture. The thing about viral conjunctivitis, you don't really have to treat them with any antibiotics as such. It's quite self-limiting. If there is a lot of irritation and itching and all of that, you can give them topical antihistaminics, or if they have nose block and such, some decongestants could also help. Also ask them to give some warm compressors or cool compressors twice a day. The thing you can tell them is that the symptoms usually do get worse in the first few days, to 3 to 5 days, and they usually resolve gradually. So if you don't tell this to them, they might think you told it will all become better and then didn't really do anything. So you need to inform the patient that that can happen.
If I might add, so in your peripheral centers, you don't have to differentiate if it's viral or bacterial and what the cause of conjunctivitis is. In this picture, if you notice, the maximum area of redness, the congestion is towards the periphery, right? It's towards the fornices. That points towards conjunctivitis. Anything that's congestion that's surrounding the cornea, that is when you have to refer out. So if it's towards the periphery like this, you can safely give off an antibiotic drop, whatever you have in the center. Tobramycin is safe, moxifloxacin is safe. But I've seen you guys have some drop called Ciplox D, which is a combination with steroid. It's not safe to give. So you should always give only antibiotic. Even if it's viral, you can just give the antibiotic drop. Yeah, please continue.
Okay, thank you. So the other one is allergic conjunctivitis. So it's a hypersensitivity reaction, usually seen bilateral. It could mimic like a viral conjunctivitis picture because it's also watery discharge. So these patients may tell you that it's seasonal, it happens time and time again. So this history kind of points towards an allergic picture. You can always give them topical antihistaminics. There's nothing wrong, as Anna said, if you're not sure, you can always give them an antibiotic drop. But then if they are coming to you again and again with the pictures, you kind of have it. They might also have other symptoms of allergies, hay fever and such. The main difference you can see in it is that they might not have any grittiness or burning or irritation as much as in a viral conjunctivitis picture. So I put 3 pictures here. These are all conjunctivitis. Could anybody tell you what each one of them would be? It's quite a simple question. And why it would be so? Is anybody ready to volunteer to do that? Okay. So I'll just go forward. So the first one, it's allergic conjunctivitis. It's not, you cannot tell from just this picture that it is allergic. It's bilateral, so more likely. And in this case, it's viral conjunctivitis. There is no discharge as such. And this is for sure, sorry, a bacterial conjunctivitis. Going to the next one, this is something you might come across, might look like conjunctivitis. They won't have much pain or anything. It could be unilateral, and you could clearly see some vessels, episcleral vessels. So how to differentiate? When you move the eye, these vessels can move over the surface of the cornea. In such a, you can give them oral NSAIDs to reduce the inflammation, and you can always refer the patient to, as a non-urgent referral, to an ophthalmologist so that the diagnosis is confirmed. You don't have to diagnose it as episcleritis, but then you can manage it in your centers. Another one would be subconjunctival hemorrhage. You might come across quite often. I used to get many patients who are very worried that there is something seriously wrong with their eye. So this is something quite benign. It usually happens if there's something, somebody sneezes, coughs, or strains. Always have to rule out some trauma, because you need to ask a good history about anything hitting the eye or any traumatic. Then you have to look for any injury to the eye as such. But if somebody having said they sneezed and after some time they saw some redness, then it increased, and it's mostly on one side and it's more of a triangular shape, you can always give them a good counseling, tell this is not something very severe. The blood will slowly get resorbed, and you don't need to really worry. And it might get worse in one day, but then afterwards it start getting better. One patient group where you need to be a bit more concerned is if it is recurring, you need to investigate for any bleeding or clotting disorders or any blood risk ratios. And if somebody is on regular anticoagulants, you will have to send them to a specialist to review their anticoagulants. Little more serious, and patient comes with a lot of pain. It's a boring kind of pain, worse at night and early mornings, doesn't let them to sleep. And they'll tell you, this is not allowing me to work. And they will have other symptoms like watering and red eye, like any other like similar things, which not as painful. So this is the severity of the issue, tells you that you need to refer this patient. You can start them on some oral NSAIDs, but then tell them to go to the ophthalmologist the same day itself. You will not really be able to manage it. So the main thing to remember is the severe and constant pain. Coming to keratitis, which is inflammation or infection of your cornea. This could be bacterial, viral, fungal, or even parasitic. So coming to, in keratitis, just like in conjunctivitis, as Anna said, you don't have to diagnose it as what type of keratitis always, because you are anyway going to refer this patient urgently to an ophthalmologist. You're not going to keep them and treat them with antibiotics for a few days and review or anything. But then I'll tell you some salient features which you might be able to tell the difference, because in bacterial keratitis, you should always start some antibiotic. One feature is that there is a reduced corneal sensation, and you can still have foreign body sensation, and you might be able to see with the pen light some branching dendritic type of opacity on the eye. What do you, as I said before, you refer the to specialists urgently, and if they can't go in a day, at least tell them to go in 2 days. Bacterial keratitis might present quite similarly. They'll have a lot of photophobia. You'll be able to see some lesion on the cornea. There might be purulent discharge, and you might get a history of improper contact lens use, so which is the largest risk factor for bacterial keratitis. So this is also an emergency referral to an ophthalmologist, and you can send them with drops, but then tell them that they shouldn't be just going home and then using the drops for a few days. They need to go promptly to an ophthalmologist as soon as possible. So that's about keratitis. So this is something we have studied in MBBS, and we said two names, hyphema and hypopion. So hyphema is when you can see some blood in the anterior chamber, and hypopion if when you see a whitish curdy white matter in the anterior chamber. So in hypopion, that's white blood cell. In hyphema, it's red blood cells. Hyphema is seen with any trauma or inflammation or any pathological neovascularization. Hypopion, on the other hand, you can see with endophthalmitis, which is very severe condition, and infectious keratitis, as I said before. So both of them need same-day referral to the ophthalmologist. Tell the patient to go promptly to an ophthalmologist. Blepharitis. This is something we might see quite common. Patient with a dry eye may be having chronic symptoms for a long time. And they might have been using some eye drops for the dry eye, and they say it's still itching and there will be some crusting in the morning. And they might even say sometimes there is excessive tearing in the eye, not always dry eye. So you can think about blepharitis. It's something you need to use a slit lamp to diagnose. But what you can always tell your patient is give them some drops like refreshed ears or such. Tell them to use some warm compresses till they are able to go see an ophthalmologist. And if it is affecting their vision and if your visual acuity is low, you should promptly refer it, because you could misdiagnose or it could be something more severe. So the main thing here is it's more of a chronic symptom and not acute. Coming to the next topic, it's hordeolum internum, externum, and chalazion. Why I put all of these three together in a slide is because you don't always have to differentiate between them to treat them. Because is it internum, is it a chalazion? Because hordeolum internum and externum, they are both infection. One mostly caused by staphylococcus. The difference is internum is with meibomian glands and hordeolum externum is glands of Zeiss. And chalazion is a blocked meibomian gland, which can also later become infected. So doesn't always have to be like you can all start them on antibiotic eye ointments or antibiotic drops like moxifloxacin or tobramycin. You can give them some NSAIDs or paracetamol to help with the pain. Ask them to do some hot sponging and oral antibiotics if it's quite severe, and if it's not improving in a few days, you can give them some oral antibiotics too.
So for lid pathologies, you don't give drops because the drops really doesn't reach the lid, right? It's on the skin. So ointment is formulated for lid pathology. So any swelling on the lid, you generally prefer ointments. Tobramycin or azithromycin, whichever, like a broad spectrum antibiotic works. Also the keratitis, like he said, anything involving the cornea, if you can see on the torchlight, refer out. You can safely give an antibiotic drop. You don't have to give an antiviral and all in your peripheral center. But the only thing to remember is never start steroids from the peripheral centers because it can worsen the keratitis. By the time they reach the ophthalmologist, the cornea might melt because the ulcer worsens due to steroids.
Thanks, Anna. So coming to the next subtopic, which is management of eye emergencies in a primary care or rural setting. So I'm going to give a few like scenarios and emergencies. So you have a patient who recently had ophthalmology surgery, or they had some injection into the eye, and they come and tell there is a lot of pain and my vision is affected. So the first thing that you should think is acute endophthalmitis and look for signs of it. And even if you can't find any signs of it, the thing is the most common bacteria that causes endophthalmitis doubles in less than 30 minutes. So you don't really want to waste the time trying to treat it. So you need to reach an ophthalmologist in next 4 hours at least. So it's very rapidly progressive. You should tell the patient it could get really severe and then send them to an ophthalmologist, preferably to a hospital rather than to a clinic. Because they might need repeat surgery, they'll need antibiotics, which cannot be managed in an ophthalmologist clinic. And if you can put an IV access for them before sending them, that should also be quite a good idea. So this slide tells you these are all endophthalmitis pictures, and you can see each one looks different from each other. You can see some hypopyon, a lot of redness, a very angry looking eye, and doesn't always have to. The first one looks a lot less red, but there's some hypopyon. So you use the clinical history and don't try to treat it, send it to an ophthalmologist. If a patient comes to you with diplopia, which is sudden, I'm not talking about somebody who has it from a long time. They come and say, from today morning, I woke up and I'm starting to see everything in two. You should always think about some intracranial pathology. It could be an aneurysm, it could be a tumor that's pressing against something, or it could be stroke. Because if you miss this, it can lead to a significant risk for life. You have to refer the patient. You should not keep the patient with you, but you should look for signs of stroke. You should do a full CNS examination. And if you think it's stroke, rapidly refer to a hospital where they can be treated for stroke and start the initial management if you can in your center.
Nuance also, you should have an urgent neuro referral.
Yeah.
Sudden deviation of eye also. They might not have diplopia. If one eye has a poor vision, they may or may not have diplopia. But if the patient is saying it suddenly become cross-eyed, urgent neuro referral, CT imaging.
Okay, thank you. So the next topic, which is also an emergency, is a sudden loss of vision. So I've divided into painless and painful loss of vision. So first I'll start with painful sudden loss of vision. It has the main common 4 DDs are acute angle closure glaucoma, acute anterior uveitis, infective keratitis, and giant cell arteritis. So I'll start with angle closure glaucoma. So patient will come with you systemically quite unwell. You can see they're unwell. They'll complain of blurring of vision. They'll complain of halos around light. They'll be having headache. They might be vomiting a lot. And on examination, you'll see a red eye with hazy cornea, reduced visual acuity, dilated fixed pupil, and when you press onto the eyeball, you can feel it is quite firm. You need to refer this patient urgently, and this patient needs a rapid control of intraocular pressures, and early treatment is more effective. So what can you do when you're calling an ambulance and or sending the patient there? Tell the patient to lie on their back, put some pilocarpine eye drops, 4%, and if you do have acetazolamide tablets, give 1 tablet and refer the patient. So you can, some things that can give you a clue is if a patient is using adrenergics or like had noradrenaline, had some anticholinergics, or very commonly you will see patients with tricyclic antidepressants in our one centers on amitriptyline. So this could give you an idea that this could happen. Or if they complain that they previously were told that they have pressure in the eye or like that, you can know this is acute angle closure glaucoma and refer them promptly. So this is an image which could give you an idea. So laser iridotomy is what we'll do if nothing else works, and you'll see a fixed and dilated pupil, and you'll see quite a bit of redness. Coming to the next topic, next cause of sudden loss of painful vision, acute anterior uveitis. In acute anterior uveitis, what you'll see is circumcorneal congestion. As Anna told before, in conjunctivitis, you'll see more to the peripheries. So this will be around the cornea, and you will see a very sluggish reacting pupil, which is irregular in shape. There are a lot of signs, but very unlikely you'll be able to see without a slit lamp. But if the patient is coming with these symptoms, think about acute anterior uveitis, and they'll also be having photophobia and an acute red eye. So give them if you have atropine eye drops or prednisolone acetate. If you can't manage it in your centers, send them to an ophthalmologist, or you can ask them to follow up with an ophthalmologist if you are able to manage it in your centers, and give them dark goggles to help with their photophobia. The thing is, if you delay the treatment in acute anterior uveitis, you can have poor visual outcomes and even have some morbidity and mortality. So we need to be, you have to have a look at the eye and see if there's any redness around the cornea. Always think of acute anterior uveitis. So this is a picture. The first one shows like very irregular cornea, sorry, irregular pupil. And this is because there could be synechiae forming. And this is in a patient, you might see like this, there is some redness around the limbus around here. Yeah. So that shows it is anterior uveitis, iridocyclitis. So the reason we give, So the reason we give atropine is because it will dilate the pupil and prevent the synechiae from forming. Okay. Going to the next topic. 1 second. Yeah, giant cell arteritis. I haven't seen any giant cell arteritis by myself, but then in UK, I've seen many patients coming with giant cell arteritis, very common thing. So you might have a patient who's already diagnosed with giant cell arteritis coming with a new onset headache, or you could have a patient coming with fever, headache on both sides. They'll tell when they're combing, they're having pain on one side or on both sides. They might say there is pain at the jaw and causing claudication, unable to move the jaw. As it could be both unilateral or bilateral. It could be painful, it could be painless. One of the main reasons, you have to look for the age. If it's usually seen in patients above the middle age, like 50 plus, and seen more in smokers and in females. And if you palpate the temporal artery, you may be able to feel some tenderness, and there could be nodularity. You should send routine bloods, and you should refer the patient. But then before referring, you should always think about starting the high dose steroids, because within hours or days, it could affect the other eye. It's only affected one eye, and it can lead to permanent blindness. So promptly refer to an ophthalmologist or a rheumatologist, start them on high dose steroids. So when you start them on steroids, the patient might have a tendency to take the steroids, sit at home, and if the symptoms improve, they might just stop it. Should tell them this is something they'll need to take for a long time, and then they might be able to bring down the dose. Also, if there are patients who can't be on steroids, you might get patients who come with tocilizumab. You don't have to start them on steroids. That is another alternative for treating it. So this is one slide which gives you a few information in a nutshell on giant cell arteritis. You can see how to examine for the bilateral temporal artery and then jaw claudication. Next topic is painless sudden loss of vision. Till now, we were talking about painful loss of vision. If there's painless sudden loss of vision, whatever the DD is, refer the patient as soon as possible to an ophthalmologist, because they will need a slit lamp examination at the minimum, and don't try to treat it. The only thing we need to be, so the DDs usually are retinal detachment, retinal vascular occlusion, it could be arterial or venous. It could be giant cell arteritis, as said before. It could have painless loss of vision, and it could be stroke. So that's one thing to remember. So you need to do a proper CNS examination and rule out stroke. And if you suspect stroke, start management of stroke and refer to a stroke specialist. Painful loss. So if as I did mention about this before, if the patient is having painful loss of vision, not just redness, and they say that they use the contact lens, you should always think about microbial keratitis and refer the patient. And if you come with somebody with contact lens use, you can always ask them, how do you use them? Do you sleep with it? Do you take bath with it? And then give them good advice on not to do that. So the next topic in emergencies is orbital cellulitis. So the only two things I want you guys to remember is, if you see any severe lid swelling and some fever and systemic symptoms, you need to urgently refer the patient to the ophthalmologist and send it to a place where there is neuroimaging available, and you can start on some empirical antibiotics because it could be life-saving. And the source of the infection in such a patient can come from the skin, the sinuses, or the venous channels. You don't have to diagnose or find any of that. You just need to urgently refer to an ophthalmologist. So this slide shows 3 different patients, and all 3 of them have orbital cellulitis. You can see the differences in more fairer skin. You can see some redness, but then in Indian population or in more darker skin tones, you might just see a swelling. So redness is not something to go by. Just look for swelling of the eye, and if they're unwell or having fever, always think about orbital cellulitis. And this, as you can see, it's just like any cellulitis. You'll draw around the lesion so that you can see if it is improving or worsening. Next, I'm going to injury to the eye. Anna, anything you want to add to the emergencies?
No, so far it's fine.
Yeah. So injury to the eye also an emergency, but I've taken this as different separate subtopics so that I can give you a lot more info and on it. So injury to the eye can be, I'm sorry, it's not very visible. I don't know, something wrong with the slide there. So it's 3 types: open globe, which has full break of the eye wall; closed globe, which is no full thickness break of the eye wall, so nothing has gone inside all the layers of the eye and gone in; and periocular, if when the injury is not actually to the eyeball but around the eyeball. So I have made a series of steps to follow when you assess a patient whom you suspect to have an injury to the eye. So first thing to take is focused history, because it will tell you what was the mechanism of the injury. Was it a high velocity injury? Was any sharp object involved in it? Or if it was caused by something vegetative like wood or blade of grass or something like that, because that shows increased infection risk and also could give us an idea on what kind of infection it could be. And the next thing to do is look for visual acuity. Even if you don't have a smell chart, you can do like finger counting or ask the patient to read from a distance something on the board or such. And if you see if there's loss of vision, then you should think about a more serious injury and you should think about referring the patient fast. Pen light examination. I'm sure you all know about RAPD, relative afferent pupillary defect. So it's also called swinging flat light reflex. So if you see an apparent dilatation of the pupils when you swing the flashlight in one of the eyes, then you should think about globe rupture or a perforation. Next thing to look for is hyphema. As I informed before, it is blood in the anterior chamber. That could tell us that it could be a serious injury to the eye. If there is limited extraocular movement, so ask the patient to move around, follow your eyes. And if they are not able to do that, or if they are having any double vision when they are doing it, think about an orbital fracture. If there is proptosis, which is if you can see that one of the eye which is affected, it's sprouting out, then you should think about an orbital compartment syndrome, and there's a lot of pressure behind the eye pushing it forwards. So that's an emergency referral. Send them as soon as possible to an ophthalmologist because they will need surgery. And one thing is, if you are suspecting even a penetrating injury, what I would advise you not to put any pressure to check if it's firm or not and stuff like that, because it could worsen the injury further. So coming to closed globe or a mild blunt force injury to the eye. So in closed globe injury, you have to always examine the eye quite nicely. Don't always assume that it is a closed globe injury. Look for any foreign bodies and see if it is going quite deep into the eye, or ask the patient to move around and see if there is anything in the sclera. Doesn't have to be straight in the front. So you need to make sure if you are sure that there is no penetration injury, then you can always treat the patient in your center itself. If you are confident of doing that, you can give some topical cycloplegics like homatropin and some topical steroids, and you can give them some antibiotics to prevent any infection. And if only in this case, if IOP is raised, if you're not suspecting, don't check for IOP or firmness of the eyeball. If you're suspecting any penetration, just send them to an ophthalmologist. But if you feel like the IOP is raised, you can give them an acetazolamide in a closed globe injury. You always patch and protect the eye from any further trauma. Coming to a penetrating or an open globe injury. So this is a full thickness injury, as I explained before. And you should always know that they may have some retained foreign bodies. So when should you think about a penetrating injury? If it is a high velocity injury, if it is a sharp object that was involved, and if it was a severe blunt trauma, then always think there is a chance it could be a penetrating injury and they need a slit lamp examination. Send them, refer them urgently, and tell them that they might even need a surgical repair, so they have to go to a hospital. And you can get an IV access if possible for this patient, because that will quicken the things when they are being referred. So this slide shows us 3 different eye. Can just somebody tell me, these are all injuries to the eye? Could somebody be able to tell if it's a closed injury or an open injury? Anybody want to try? No? Okay. So the first one we have here is open globe injury. It's not very clearly visible sometimes. That's one of the main reasons I put it. You can see that there is some blood here. They might just come with telling that they're some redness on the eye. And you can see that the pupil is irregular, more of a tear shaped. And again, see the second one, even though it might look quite severe, but it's a closed globe injury. The third one again is an open globe injury. You can see that the pupil is more irregular here. That's something you might be able to see in an open globe injury, that the pupil is not very regular. And that could give you an idea as to what type of injury. But if you are not sure, refer the patient, because I'm sure the one in the middle, if I see it, I'm not going to treat in Bond Center. I'm going to refer the patient to an ophthalmologist. Other type of injury that can happen is involving chemicals. So this you might come across very commonly, especially in a rural setup. They might be using fertilizers, they might keep kerosene here and there, they may be using some lime or other things that can cause injury to the eye. So always ask what caused the injury. So is it what type of, is it an acid, is it an alkaline solution? And if so, try to find out if it's something very severe, you need to refer them urgently. And if they ask if there's any pain or blurring of vision, which gives us an idea of how severe the issue is. If there is blurring of vision, send them after giving a good irrigation with saline. Should always give anesthetic drop like Paracaine, which you will have in your bond centers. So if I don't think this is possible in any of our bond centers to check pH and stuff. So I would advise you to irrigate really well so that whatever the chemical that's causing the injury is being washed away. And they might require corticosteroids, antibiotics, and anti-inflammatory drops and some mydriatic drops. But if you are not, if you suspect that this could be more severe, always refer to an ophthalmologist. And especially if you think it's an acid or a poison like organophosphorus or something like that. Coming to corneal aberration can be because of an injury to the eye. It could be because of foreign bodies. It could be simply because of an improper contact lens use. So they'll come to you with a severe eye pain and having foreign body sensation. You should, first thing to do is exclude an open lobe injury, look for any hyphema, because these need you to refer the patient urgently. But if you can exclude all of this, assess visual acuity, go by the flow chart I had showed you before. Go through all the steps, make sure that there's nothing more severe. Always evert the lid to check if there is any foreign body in the lid, behind the lids, upper and lower, because they will, if you miss that, they will keep causing more and more aberration, and the patient will keep coming back telling it's not improving. And if you think it's uncomplicated, if it's small and it's not affecting the patient's vision, it's not in the center really, and you can clearly see that there is no foreign body there, you can always give some topical antibiotics, topical or oral painkillers, and tell the patient that it should become better in 24 hours. And if they see it is worsening, they should go to an ophthalmologist. But if you see a foreign body in the eye, what to do is, as I said before, evert the upper eyelid to look for any conjunctival foreign body first. And if you can remove from the conjunctival foreign body, is more safer to remove. If you can remove that. And give copious irrigation. So it says if it's more than one foreign body, you say it's use one whole bag of fluid to wash it. And some easily dislodgeable foreign bodies might just dislodge by washing it. There is a way to remove the foreign body. And I know a few of my friends who did remove foreign bodies in their bond centers and they had slit lamps and such. I have not done that, and I wouldn't attempt it unless I am trained to do so. But then the steps are such: you need to use aseptic precautions. You can use proparacaine 2 times 5 minutes apart, and you separate the eyelid. You can use a needle, but always go parallel to the eye. Never go straight in, because you will cause some other injury unnecessarily. But this is, I would not advise you on doing it if you have not seen it being done before, you've been not trained to do this before. And main thing to remember is give them some antibiotics, put some proparacaine, because they've been a lot of pain most of the times. Send them to an ophthalmologist, tell them that they need this to be removed. Otherwise, they are not going to feel any better. That's to the end of the presentation. I'm sure it helped a lot of you with most of the common ophthalmological presentations in your bond settings. And Anna should be able to answer any of the questions you can put in the chat. Anybody has any questions? Or Anna, do you want to add something to the last few slides or in general?
In general, yeah, so 90% of the cases you might have to refer to the opthal. But some common cases, like in bond centers and all, they might come with history of the cattle tail hitting the eye or vegetative matter like crops or soil entering the eye and all. Just to be safe, always refer out because there's a high chance of corneal ulcer forming. Contact lens use at all unlikely in a rural setting. But this history, if you get, then it's better to refer out so we can rule out keratitis. Then, like I said, any condition around the cornea, refer out because it means it's involving the cornea, anterior chamber, or the contents inside the eye, which cannot be managed in the peripheral center. But it's peripheral redness if you're seeing, you can manage with topical antibiotics. Then foreign body removal, never use a needle without a slit lamp. And what you can safely use is a cotton earbud that you use to clean your ears. You can use antibiotic drop on the tip, sterilize it, and then after putting the topical anesthetic, you can gently sweep and clean and remove it. But never use a needle without a microscope. Other cases, open globe injury, when you're referring out, never patch it with cotton or gauze. If a plastic shield is available, which is away from the ocular surface, you can apply it with a tape. But otherwise, preferably nothing. Just the normal coverage of the lid is more than enough. The gauze itself will cause more contamination, or using antibiotic drop topically, that will cause more contamination. So refer out immediately. If you see the integrity of the globe is lost, just refer out immediately without anything if the plastic shield is not available. Closed globe injury, even if the eye looks quiet and all, it's always safer to refer out because they might have mild irritation of the iris, which causes spike in the IOP later, maybe 2-3 days later. And it can cause damage later on. So even if it's blunt injury, safer to refer out. But if they're not willing, obviously not a big deal. Then the most important skill that you can use is the pupil examination with torchlight. If you see it's not round and briskly reacting, if there's any like unequal size of the pupil, or like he said, RAPD, relative afferent pupillary defect in the swinging flashlight test, or if you see that there is peaking of pupils, which means there is a pathology going on. Then another neurological thing is the movement of the ball, the globe. So that is cranial nerve 4 and 6. So if that is affected also, it means there's some pathology going on in the back. Immediate referral. So anything to do with the pupil and the movement of the globe, you have to immediately refer out. So there's very few things you can manage, but the most important thing you can help us with is the chemical injuries that you come across. So the copious irrigation in the first few minutes they come to you, that will preserve the eye. Otherwise, the can deteriorate in a few hours. The cornea will melt in a few hours. So that initial washing, ideally you should use at least 500 ml of ringer lactate. So you poke a hole with a sterile needle and then squeeze that bottle out till it washes. So when patients come to us with a history of given a proper thorough wash in the peripheral center, their outcome has been like really good. So that the further management will be medical in a tertiary center, but that initial wash is very, very important. And the other cases that might come to you with is thermal injury, like pressure cooker blast and maybe electric shock, that can also cause corneal damage and all. So those cases also, you don't have to give a wash, but always give a referral out to opthal. Yeah, these are the most common ones.
Is there anybody with any doubts? And you can always put these doubts in our chat or even in our discussion group. And Anna and myself, Anna should be able to answer these questions. I don't know how much I would be, but then Anna should be able to answer your questions there. You can, if you have any doubts at the moment, you can ask them. Otherwise, I think we can end the session in another 5 minutes. And there is we will be sharing a feedback form. Tara, could you share the feedback form on the chat?
Yeah, just 1 second. So I'll be putting a feedback form on the WhatsApp group as well as the chat box here. Kindly do give me your feedback because this helps us plan our next sessions as well and lets us know how we can improve. So please do fill the feedback form before you leave this meeting. I'll just put it. Yeah. It will be on the WhatsApp group as well. So please do fill it.
And Tara, I think we can stop the recording.
Yes. So thank you everyone for joining. Thank you especially to Dr. Daniel and Dr. Anna for taking time off their busy schedule to take this session. Thank you so much, and hope to see you next week. Thank you.
Thank you all.
Okay, bye.
Have a good night.
Bye.